Thanks everyone for being here for the Hospice and Palliative Care Grand Rounds. Very excited to have Dr. Leigh Vaughan with us today. She's been like a mother to me in a lot of ways in hospice and palliative care, except for the age. She's way too young to be my mother. But I couldn't think of a better person. So this is your first time here. Make sure you sign up for CME. If you have any problems with that, just let me know. I'll be putting a code into the chat at 45 minutes after the hour so that you can text and get your CME. But I couldn't think of a better person to give Dr. Vaughan's introduction on maternalism in shared decision-making than my mother. So Mom, take it away.
Okay.
Let me make sure that, yeah, you can see Mom, good.
Okay. Oh,
You
can you
good?
see me? Okay. Well, hello, everyone. A longtime listener, first time opportunity to introduce. Dr. Leigh Vaughan is an internal medicine physician who specializes in palliative and hospice medicine. She's been in academic medicine and clinical practice for 25 years, first at Memorial Sloan Kettering Cancer Institute, and now as faculty at the Medical University in South Carolina, where she now works in the inpatient hospital setting. Her professional time is spent in the care of hospitalized patients and teaching medical students, residents, and fellows. She has served as the Associate Program Director and Program Director for the Hospice and Palliative Medicine Fellowship since 2025. Her research interests include the intersection between palliative care and ethics and health disparities at the end of life. Dr. Vaughan, welcome to the virtual Grand Rounds. And on a note, thank all of you for doing what you do. I see a lot of faces who don't know me, but I feel like I know you because I've been watching for a long time. So thank you.
Thanks, Mom.
Beautiful introduction.
Now I have to go play cat, taco, goat cheese pizza.
That's the best. I've never been introduced by anyone's mom, and that's the best. Genius. So hello, everybody. Ben was just making fun of my being technically challenged, hence saying that, you know, that moms sometimes don't know how to work technology, which was sadly true. Anyway, yes, I am Leigh Vaughan, and the only thing that I was gonna alter from the introduction is I think that I must have had a typo when it said I work in the inpatient hospice unit at MUSC, because that would be a news to everybody, meaning that we still don't have one at in Charleston, but we certainly hope so. Anyway, I am always privileged to be able to collaborate and to work with Ben and the group in Columbia. It's so nice to have great partners across the state. So one of the things that I wanted to talk about today is maternalism in shared decision-making. And I think that those in the audience will recognize it as really what we've always done in palliative care. We've just named it. All right. So those are my objectives. I'm going to define it. I'm going to illustrate maternalism in a case, and then I'm going to contrast it to paternalism. And I'm going to give a smaller contrasting statement. I mean, a case just to maybe define how maternalism is inappropriate. So, you know, every palliative care talk I give, I always begin with pictures of my family. And is that because I wanted to show y'all my new puppy up on the right, Butter? Or is it because I wanted to show you why I'm in Newport, Rhode Island right now, even though I live in Charleston, South Carolina? Because the girl who's running in the rain, I'm up here to watch her run the Newport, Rhode Island Marathon, which is her first. But I think why I do that in palliative care, or almost any talk I give, is because the heart of what we do is learning about the fabric of our patients, what the collage might be. And we learn that through our questions, through our interdisciplinary team. And the heart of shared decision-making and navigating complex decisions is really getting to know the values of a patient. And so putting pictures up there allows me to boast, but it also keeps patients and their values at the forefront of everything that we do. So I think first we will start with some definitions. Shared decision making is really now the norm, but I think it began with paternalism back in the early to mid 20th century, which, that was entirely clinician guided, and that means male physician guided without considering the wishes of the patient. It was just doctor knows best. And then the pendulum swang all the way to autonomous-based decision-making. And that's how we got the right to make decisions about our own healthcare. And that, an important movement. It brought us informed consent. It brought us the right of refusal. And it brought us really patient-centered care. But the challenge of either extreme is, on autonomous-based decision without the clinician input, we are almost abandoned to our own autonomy. And so that's why I think shared decision making evolved. It's the definition of it by Quill. The clinician shares information about illness and treatment options. The patient contributes her expertise about her own goals, attitudes towards risk, and the value she places on various outcomes. Then combining their perspective, they negotiate a solution that is uniquely suited for this patient. So shared decision-making was endorsed in 2004 as sort of the best way forward, and has been endorsed by all the major organizations. So next, I want to introduce you to Alexander Kahn. If you have never heard of Alexander Kahn, he is a pediatrician and ethicist who has done a lot of work in the field of shared decision-making. He's also an intensivist, which certainly alters much of his work. And so what he did is to say that shared decision-making really is a continuum. And again, we have this sort of patient or agent-driven. And then at the very opposite end of the continuum is entirely physician-driven. And what we know is that the data supports that neither of those are really favored on its extreme edges. And in the middle, we have physician recommendation, equal partners, and informed non-dissent. And I think to know about physician recommendation and equal partnership, at least on Kahn's continuum, he is defining those as entirely decision is based on the patient's values, not the values of the clinician. And so it is, oftentimes we say, based on what you've told me, my recommendation is that. But it is distinctly different than the physician giving his or her own recommendation. So I want to kind of hone in on this area of informed non-dissent, because it's one of the things that we talk about in our case. So informed non-dissent, it is where the provider bears the major burden of decision-making. It's guided by the patient's values, but the provider is determining the best course of action based on the patient values. I would offer that we really don't do informed non-dissent, meaning we don't use it as a technique of communication in routine matters. It really is in sort of extraordinary times. It makes sense that Kahn is sort of the one who put forth or better described it, meaning being a pediatric intensivist. And it's where the medical teams state what will and will not be offered. And they make a strong recommendation. And in this technique, it allows families to be off the hook for painful or an agonizing decision-making. We know this well in palliative care. Silence is acceptance of that recommendation. Now, of course, patients and families have the right to veto. And then in which case, whatever the course of action that was recommended would not be taken. And I would offer, this is a pretty significant jump from equal partnership. And I think those of us who have these conversations feel that there's a room to incorporate other styles in this continuum and other techniques. So that brings me to maternalism. So, I really give a lot of credit to Laura Specker-Sullivan. Many of you who are familiar with, she is a bioethicist previously at NUSC in Charleston and now at Fordham. And Dr. Specker-Sullivan and her partner, Dr. Niker, really in 2018 defined how maternalism in bioethics and medical decision-making could be a sort of newer described technique. But again, I would offer for the things that we have done for a long time. It's a style or technique, but it's not a linear point on that continuum. I think it's a way to conceptualize in an interaction with a provider and patient and family where clinician-guided decision-making exists within a trusting relationship. It's an independent process that balances patient and surrogate preferences for value-laden decision-making with the clinician's responsibility to maintain the boundaries of acceptable medical practice. And, you know, I have the privilege of working with Dr. Sullivan, Specker Sullivan, and I'm not sure at the time, she is, you know, a bioethicist and a PhD, not a clinician. And so that expression in the boundaries of accepted medical practice, I'm not sure if you haven't been a clinician seeing where we have, I think at every level of healthcare, sometimes exceed the boundaries of accepted medical practice. I found it to be incredibly insightful as a non-clinician to include that in her definition. So I think maternalism can at times, not always, again, this is employed in certain contexts, but it can result in actions for the benefit of another person in a way that takes that person's autonomous agency into account, despite no explicit expression of consent or assent being given by the person on whose behalf the decision is made. So we're going to go over two cases here. One is a 587-day hospitalization. It's a complex surgical case. And then we're going to spend the majority of time there. And then I am going to introduce a contrasting, really, a vignette. So bear with me, the details of this case are lengthy, but I think that the details are really essential to get at sort of the heart of the case. So Mr. X was a 70-year-old gentleman, African-American gentleman with known coronary artery disease, hypertension, and stage 3 chronic kidney disease, who presented with a non-STEMI and underwent a multivessel CABG. He had massive intraoperative bleeding, complicating the procedure, and he had asystole closure. The post-op course was further complicated by cardiogenic and hemorrhagic shock and an acute kidney injury requiring continuous HD. Post-op day 12, he had a large left middle cerebral stroke. He had continued respiratory failure, which eventually led to a trach and a PEG. So following the stroke, the ICU had held conversations with the family. And sorry, these are, there's some abbreviations in here. So SCT is surgical care team. They held conversations with the family, and the family instructed the teams to do everything possible. 3 months after the stroke, the neurologist had found no interval improvement in the clinical course and felt that Mr. X was likely in a chronic vegetative state with a very low likelihood for meaningful recovery. So those of us who practice in the state of South Carolina know that our home state has no facilities of which you can have a trach and a PEG with poor neurologic condition who requires dialysis. During discussions with the surrogate decision maker, who is the patient's daughter, the poor prognosis was discussed, and the surgical primary team offered the option of transitioning to comfort. The family remained reluctant to withdraw aggressive care, always hoping for a miracle. The hospital course was protracted and complicated by pressure wounds, recurrent GI bleeds, in and out of the ICU, multiple trips to the OR for debridement. He would be weaned from the ventilator, but always requiring the trach for airway clearance. And he really had no neurologic improvement for the remainder of the hospitalization. Again, 567 days. Several more family meetings were held over the next year, and the surrogate continued her wish that the team, quote, do everything. She echoed the family's hope for a miracle and their belief that through God, all things were possible. And so I think the broad consensus from the healthcare team was that progress towards clinical improvement was at an absolute standstill. So if you look at this continuum, again, going back to Kahn's continuum, where we have patient-directed all the way at one end, physician-directed all the way at the other end, there's physician recommendation, equal partnership, and informed non-dissent in the middle. And so where are we here on this continuum? I would say that we are really at patient-directed here. The physicians had made some recommendations, but there had really been no change. So on day 565 of the hospitalization, the surgical team said, let's have another family meeting. And they called the palliative care team. They called an ethics consult. They called the neurologist. And they were all wanted to discuss the lack of clinical improvement and really the paucity of options for leaving the hospital. And so it was here that palliative care really began engaging the family to build rapport, provide information, and learn more about the patient values. And so we did it in the way that all palliative teams recognize, right? Multiple visits for both symptom management and chaplain support. And a lot of the family was not close, and so a fair amount of this was over the phone, but it was constantly checking in with the family and really sitting and listening. And so what we learned was essential to the resolution of the case. And the first was the patient's daughter, who was the surrogate, was very, very anxious about making a decision by herself. All the conversations had been her alone. And she said that she would have to have full family support that would be essential to the decision-making. Our chaplain was able to support the family's very strong faith and learn that they were accepting of God's will, but very fearful to make any decision that would appear to stand in God's way or usurp God's plan. They relied on their church community for support and guidance. And they even shared that one of the patient's brother was a pastor for the church and had been instrumental in the decision-making among the family, but never directly involved in the previous conversations with the surgical team. And then I think the daughter shared how her father had been a leader in the community, and she directly referenced racial tensions in South Carolina and inadequate healthcare for African-American patients, which we know still do result in inequities across racial lines. And in these moments, the palliative team does sort of what we always do, which is hold space for these concerns, acknowledge her very real fears, and really listen and learn about how the history of where she and her family have lived and our team practices and the surgical team practices really still informs the present. Lastly, what we learned through some of the conversations was the daughter just wanted her dad to get the best healthcare. She said it over and over, but she was very open to discussing what is the definition of best. She wanted her dad to get the same care that my dad would. So what we, in the palliative, what our group really advocated for was to have a pre-meeting. We said that without having a pre-meeting with all the subspecialties present, that really we couldn't go forward and make a plan. So this was an opportunity for the palliative team to help guide the other teams on a consensus of what interventions were going to be recommended and which ones were not going to be offered to the family. And then based on what we learned in our visits and phone calls, the palliative team advocated that an alternative approach was essential. They were never going to withdraw aggressive care with their loved one or life-sustaining treatment. But not escalating care when complications arose was definitely an approach more in line with the patient's faith. And then we advocated that best clinical care in the context be very clearly defined to counter the perception that there's nothing left to do. So the pre-meeting was essential because we took these broad intentions of not escalating care and we narrowed it down to very specific responses to the expected clinical scenarios. And in a way, I would say perhaps we are practicing here maternalism to our colleagues. So in this pre-meeting, we got very granular. When the oxygen saturation declined, morphine would be provided. When fever developed, antipyretics would be offered. When the inevitable pulmonary secretions increased, which would always require him to have been back on the ventilator, we weren't going to respond with mechanical ventilation, but rather meds to thin secretions and to treat dyspnea. And when the inevitable complications plaguing his hospital course arose, it would be comfort medications rather than CT blood cultures and another trip to the ICU. And in this pre-meeting with the teams, what we advocated for is that continuing hemodialysis and tube feeds were essential to the family, and they had to be continued. And I think initially we got some pushback from our team. They said, how can we be providing HD and tube feeds, but we're foregoing labs and daily tests and imaging? But what we would argue is that this middle ground can spare the family from having to abandon what all along that they've seen as we have told them is necessary and that they now see as essential. And I think what we argue is that it is the maternalistic provider who navigates the gray zone. And I think our colleagues are very used to a dichotomous choice, aggressive care or comfort. But finding that middle ground, I think, is what we do in palliative care, and I would argue as maternalistic providers. And these are very common themes in what we've done, but it was wholly novel to our surgical colleagues. So where are we now on this continuum? Patient directed on one end, physician recommended. I would vote that we actually are an equal partnership here, meaning giving on the or endorsing the wishes of the family to continue hemodialysis and tube feeds, but then finding some things that we were not going to offer. And so I think the language of goals of care conversations that, so we all co-lead family meetings all the time. And co-lead means that you allow other teams to speak and use their own language. But it is sometimes that language that we in palliative care have to sit a little bit on our hands and sometimes wish that we could use different phrasing. And so I think when a patient's prognosis is poor, families ask, do you want us to withdraw life-sustaining treatment? Which sounds a lot like giving up. Asking if you'd like to stop therapies of which you got consented for again and again seems as that we're going to stop caring for their loved one. And the phrases in the meetings that we go to, we all recognize, do you want to withdraw support, remove the ventilator, turn off the pressors? And families are in the position of deciding to stop care that for days and weeks they've been told is necessary, required. I think when we didn't have paper charts, obviously, in anymore, but if you could sort of extrapolate the number of times that family consented to blood, a new line, a new trip to the OR over 500+ days. And each and every time I imagined that the language that they were told, your dad needs a new line, or he has got to go to the OR. And so imagine how different it feels when we are suggesting something different. And so I think that this change is often met with confusion and anger from families, and they feel that we're asking you to pull the plug. And so I think in a mixture of fear and confusion, families respond to, we just want you to do everything. And so at this meeting, we really advocated that language was essential and that it was endorsing the patient's and family's values and having gotten to know them that was going to allow a peaceful resolution for this family. And so I think at this meeting, what we did was to recognize that discontinuing interventions that had kept their dad alive was discordant with the core belief that only God is in charge. And we knew that any request to make a decision felt like our asking either them or us to play God. And so the essential pivot to no escalation of care allowed them to be off the hook, but also not abandoned to their own autonomy. And so I think the miracle language is something that we're very familiar in palliative care. This is territory that we understand. And so we said what we always say, we too hope for a miracle. But, you know, I joked when I gave this presentation at Ben's meeting a couple of weeks back. I said that I always thought as an Episcopalian for 50 something years that the expression man has done all that man can do. I thought it was from the Bible. And my chaplain had to correct me quickly. She was like, that's not. I was like, isn't it from Proverbs? She said, no, Leigh, you just made that up. But I do think that that expression resonated with this family, because what we were saying is that the care and the prognosis has exceeded what we can do. We cannot do anything to change the trajectory of his illness. And I think it allowed the family to see that the medical team had really exhausted all efforts and we had reached the bounds of our limited capabilities. But I want to be clear, we were explicit in our opinion, though supporting their belief, their wish for a miracle, we were explicit in our opinion that time was short and that we did not anticipate meaningful recovery. But we were respectful of the family's belief that only God controls life and death. So I think when we think about informed non-dissent, how was this at play in this meeting, moving a little bit down the spectrum? Because at this meeting, we talked about the interventions, the surgical interventions, trips to the ICU, going back on the vent, adding back vasopressors, or doing CPR were not beneficial, and that they would not be offered. And that when these inevitable complications arose, that we would respond with comfort. And what we found is that very quickly, the family gave their assent to these statements by saying, everybody do their part and let God do the rest. And Alexander Kahn talks about in one of his papers, again, his patients are always children. And he said, this agreement that's not necessarily explicit, we do not require families to say, let my child die, that is just unnecessary, as long as you're clear that families understand that you will not be providing these interventions. And so, you know, I think it's time here, you know, we can certainly open up for discussion, but I would ask you to sort of remember at this point, which is like, how comfortable is your institution with these tenants? Is there a comfort level among your IDT, or would you find that this would not sit well with your IDT? Do you find that there's a comfort level with making recommendations among subspecialists? And how does it differ from maybe palliative teams? So I think I am fortunate enough that we wrote up this case and that we got this case accepted to Jackson. It got published just this month. And the reason we chose a surgical journal rather than a palliative journal is that I think this felt novel to the surgeons, but very in the territory of palliative care. Their initial editorial reviews gave us significant pushback. Perhaps you have overstepped. You know, I mean, they were very thought-provoking questions, painful for all of you who do rewrites and rewrites and rewrites, painful, we know, but it actually pushed the paper to be far better. And one of the things that they asked us when they sent back their comments was, do you think you've overstepped? Do you think you've made assumptions? And how did you establish the connectivity with the family and extract their values? And what we realized is that the initial draft of the paper just had statements such as the palliative team reached out to the family to obtain their values. It just stated it. But in the after the comments of the surgeons being a little bit fearful that we had not done our due diligence, we were then reminded that you have to you have to spell it out. You have to explain and not assume that this is just the territory of palliative care, meaning we always find out your values. We always sit with patients. We always are attuned to their spiritual, existential, psychosocial, and physical needs. And so I think I had not been explicit enough in the first draft of sort of explaining the work that we do. And so in the rewrite, what we learned is that best care for their loved one did not necessarily mean aggressive care, that priority for full family to be involved was essential, and that being mindful of their spiritual priority was really the backbone of the discussion. And so how did we, what kind of language reflected these three things that we learned from the family, from our engagement with the family? Again, we talked to the family and the daughter a lot about best medical treatment given his condition. And so we used expressions such as, I think we will use treatments that are helpful and beneficial, because going back to the OR is harmful and it is ineffective. We were clear to define best care, pain management, skin care, mouth care. And again, being explicit rather than assuming people know what we're doing in palliative care. We reframed the expression that we hear all the time. We want you to do everything. We reframed it to let's do everything that is helpful, but nothing that is harmful or ineffective. And then we also recognized in our multiple conversations with family that it needed to be a much larger group. It needed to be much larger on both ends in terms of the family meeting. And so we held it virtually, at the family's request, and it allowed a substantial number of family members and providers, including the palliative care, physician, social worker, chaplain, the surgical team, the ethics team, neurology, nephrology, and I think really importantly, the nursing staff who had cared for this gentleman for over a year. The spiritual support, how did we do that with using the language of maternalism? And I think that the lion's share of the work in that meeting was really done by our palliative care chaplain. And so she was essential, saying, you know, if God wants to do a miracle, he can. But said, if it happens, it would be out of human hands. All of the care teams supported the family's expression of faith and hope, and even their insistence that their loved one would be healed against all odds. And we did not equate those expressions with denial, poor understanding of prognosis. And so if you do not know the work of Corey Kennard, he's a pastor with palliative care expertise. He wrote a beautiful paper about hope and the hope for a miracle. And he and the care team members expressed support for the patient's statement of hope by understanding that they were expressions of their worldview or a wish, and that these expressions are comforting. Saying that you wish for a miracle is comforting, or that they were telling the doctors that they believe one way or another God will heal on this side or the next, indicating that maybe the healing comes in the afterlife. And again, despite an overwhelming poor prognosis, we affirmed that only God is in charge. And I think that acknowledged the family's faith, but also the fallibility of prognostication. So in summary, I think maternalism at its best balances the interests of all involved in caring about for the seriously ill and results in decisions that are best for patients and families, but sometimes those that they cannot make for themselves. And it proposes that a clinician can intervene on a patient or surrogate's choice without the presumption that you know better or distrust what they would choose for their own interests. So this is a much smaller and shorter vignette where I just wanted to contrast it and how I think maternalism is not always appropriate. So this is a gentleman I saw right before the palliative care conference in Columbia just a few weeks ago. And it's a 24-year-old gentleman who had lifelong anxiety depression and cirrhotic liver disease and a MELD of 32. He was not a liver transplant candidate because of alcohol and anxiety. Palliative, which was, by the way, refractory to multiple modes of treatment. And so palliative care was asked to see him for goals of care and symptom management. And of course, the page asking us for the consult, in all caps said, and he's full code. And so the palliative, as the palliative MD, I came with my interdisciplinary team. I think I came with my chaplain, and then subsequent to that, one of our palliative social workers came, and then subsequent to that, I think we even sent in some of our arts and healing and a Reiki therapist, and every angle that we tried to build and to connect was met with a sheet over the head. I don't know. I can't talk about this now. I can't talk about this. I'm so anxious. I can't. Even suggestions of maybe new pharmacologic approaches or new non-pharmacologic approaches to anxiety, all of it was met with an absolute wall around the patient that he put up. And interestingly, his mom was at bedside, and he was 24, but he seemed much younger. And she didn't want to engage with us. And it's hard to know if she was trying to empower her son, defer to her son. It's hard to know the dynamics because the two of them just really wouldn't connect at all. Note, he was sick, right? Relatively hypotensive, tachycardic, and gram-negative rods with urine output it felt like dropping by the hour. He was alert, oriented, not at all encephalopathic, and extremely anxious. And again, the team is reminding us to help him understand his prognosis. And so, he didn't understand his prognosis. And if he did, I couldn't engage with him. And any really efforts to keep digging were just met with a sort of increasing exasperation with us in his room. And I think we have to remember in palliative and in medicine, and all of medicine, that first do no harm. And I felt like a goals of care was just not beneficial to the patient and his family. And I think that it was mainly his anxiety and not, for instance, metabolic encephalopathy that just prevented him from engaging and rapport building. And the teams kept reminding us about sort of this impending doom and, expected trips to the ICU, which would likely follow with all, escalating forms of life support. But what we responded is that his poor prognosis is mostly sort of beside the point, because you can't come in and tell somebody what is and isn't going to be offered if you can't be in that trusting relationship. So in conclusion, I think maternalism is a place for the pendulum to rest when all options are not equal or equal or even possible. And clinicians want to communicate a recommendation while also taking the patient's values into account. And, we always give Dr. Specker-Sullivan and her colleague, Niker, the credence for terming the term maternalism in medicine. But I actually found this Dr. Petrillo on a Jerry Powell blog back from October of 2014. And I really love that. So I am certainly happy to take questions. Let's see if I can get out of this. And
thank you, Dr. Vaughan, for this presentation and kind of helping reframe the way we think about surrogate decision-making or decision-making in medicine. So awesome presentation.
thank you.
But before I open it up to questions, you're welcome to unmute and ask a question or put it in the chat. But if you're looking for CME credit, I did put the code in the chat for you to text to that number. If you haven't set it up and you want to, just shoot me an email and I will walk you through that process. Does anyone have any questions for Dr. Vaughan? Go ahead,
Yeah.
Amen.
I don't really have a question, but I just wanted to comment. I really appreciated the thoughtfulness you talked about, kind of reclaiming language and having like that pre-meeting with the team. I've been practicing for a few years, and I think I spent a lot of time in my fellowship thinking about this language of aggressiveness. I remember as a fellow trying to like reclaim that and be like, we can aggressively manage their symptoms at the end of life, and trying to commandeer that word back. We have the power to do that, and try to make it a dichotomous choice of, knowing that time is probably shorter than we want it to be. How do we spend that time? So I really appreciated your comments about language. I think that's really impactful.
Thank you.
Lauren has her hand raised. Another Halonk person, right? Victoria, did you have a question? Oh,
I did. I'm sorry, I was in transit, so I wasn't sure.
sorry.
No. A fascinating discussion. And thank you so much for this thought-provoking time. One of the realities I always have trouble reconciling with is these principles that govern our practice and then the metrics of quality that teams are held by. It's the external pressures, the transplant teams, 15-day, 30-day, 60-day outcomes are tracked. And then the case managers putting pressure because of the length of stay, and so many factors that are actually forcing us to be in conversations that shouldn't be happening at that particular time. I'd appreciate your thoughts on reconciling that element of our reality with what we're learning today.
I don't know, but I will tell you, meaning that I feel the exact same thing. And it's interesting, I showed, that, day one is when he comes in for his NSTEMI and has the cabbage, and that really it's day 530s or something. We've changed the date so much. So if you look at if anybody goes back to read the article, it now says day 600, and that is because Jax really wanted us to anonymize the case, and I respected that. So the dates are a little bit all over the place, but I think in general, there were many meetings along the way, right? But the primary surgical team who had done the cabbage wasn't willing to not offer or to change the approach. And it was only when the hospital leaned very hard that, there is no disposition for a patient in our state of which you are with a trach and a peg, and it's really dialysis, poor neurologic, and a trach, that there's just really no option. And so I think that the surgical team got enough pressure, as you're describing, from the hospital to be open to alternative approaches. And I think what they were so surprised is simply by reclaiming language. And I don't mean simply, because the work that we do isn't simple, right? And the skill that our interdisciplinary teams bring, and that the chaplain brought, and that the social worker and all the essential volunteers and the nursing care on that floor was essential to building this rapport, that then when the surgical team got ready to say, okay, we are willing to take a different approach, the family very quickly agreed and they were in distress, as in, our loved one, this is the end, but it was not a contentious conversation. And what we all wondered is, gosh, I wish you'd called us earlier, right? Like, I wonder if we could have done this same thing at day 100 instead of day 500. And so those external pressures are both so troubling, the quality metrics, not troubling because they always have a good intent, but they are also something that we have to navigate, right? But in this case, those metrics are what sort of pushed the primary surgical team to finally consider different approaches.
Yeah,
Thank
I
you.
loved, yeah, reclaiming the language of Like Anna said, aggressive care, well, aggressive comfort care, or what does it mean for the patient to need something? There's a couple comments in the chat. I wanted to highlight Anna's last comment, which was your comments about pressure from the hospital make me think about the ethical implications of limiting care. What happens when we've created a population of chronically critically ill folks who require care in an acute care setting? Is it palliative care's responsibility to curb that phenomenon?
No. You're right. I do not see myself as a length of stay steward, right? I see that what I will take from this, and again, why I began each talk that I give with pictures of my family, is that Mr. X was somebody else's family, right? And that daughter who I got to have the most interaction, and then the pastor brother, what they wanted was best care. But always best care had only been proposed one way. And so for me, this was I'm not a length of stay person, right? That's not what I do. My job is it's all of our jobs. I mean, I'm speaking to the choir, and I'm thankful to have this audience. But what we do is learn about the family and the values, and learn about their fears that this is a difficult state if you're an African American patient, and having been victims of inequitable care, they were fearful that not going to the 12th operation for debridement meant we weren't going to give good care. So it meant listening to that. For me, it has nothing to do with length of stay. And I think it's a side effect of what we do, but I know, that's why I feel so lucky to work in this field. It is just not that is not what I walk in to do.
To be told the patient needs a trach and a peg, and they need dialysis, and now they need debridements, and they need antibiotics for their pneumonia. And then all of a sudden, another team comes in and says, well, they don't really need that. This may not be helpful.
Yeah, and I think the family was, the word reasonable, how many times in palliative care have we all sort of cringed at that word, like reasonable because you agree with me? But this family was absolutely able to weigh beneficial, burdensome, harmful, and effective best care they absolutely followed the argument that we were going to provide the most dignified care, and that time was short no matter what decision that they chose. And I think the surgical team was surprised to see the family comfortable with our reclaiming the language.
There are two questions from a couple minutes ago that I wanted to go back to, Dr. Vaughan. The first from Eric Marty, who asks, what do you think would have been the right approach to team decision-making on the last case?
Yeah, I think that there are just patients that we can't reach, right? And what I saw was his primary problem, other than sepsis and liver failure, was untreated depression, but not for lack of trying, right? So a lot of things, he had been really quite refractory. But I would have liked to have seen us, because we weren't there early enough, right? How about some of the sort of out of the box thinking that we could have collaborated with on psychiatry? I don't mean to throw out ketamine as like just our easy, like, well, why we didn't try some ketamine? But we didn't have time to try, new pharmacologic approaches, such as, doubling up some of the meds here. We just didn't have time because he was so sick. So I think in that space where you don't have time to treat the primary problem, which was untreated depression, that all you can do is walk with a family and sit in their anxiety and, continue to be, as they say in chaplaincy, the ministry of presence. And unfortunately, he went to the unit, he didn't make it out of the unit, and all of those things happened, but first do no harm.
Christian from the University of Louisville. What do you think about the possibility that maternalism may propagate the stereotype that palliative care is about handholding and perceived as weak or soft, right? If we're walking on this journey and advocating for treatments that other teams don't think are appropriate, are we just weak?
That's a great question. And since Ben's mom introduced me, I embrace it, right? I do handhold. I do. What I also try to do is to publish thoughtful papers, to teach, to use evidence-based medicine when I can. So we can be both. But I fully embrace hand holding and all the stereotypes that come with it. But if you're really interested in palliative care, so you have to spend the whole day with us, right? And see that we really are trying to do our best to use evidence-based medicine and be just like other specialties, but they don't always hold hands. And I think a little hand holding would have gone a long way, perhaps on day 72.
I mean, all of the studies show that palliative care doesn't impact length of stay if we're involved after day 4, because the plan of care has been set, right? The family, the patient, whoever's able to participate, they know what direction their course is. They may not know why they're on that direction or where their ship is going, but everyone knows kind of what the plan is. So, if there hasn't been that thought of, well, we may be sailing to a place that you don't want to end up, even in the best case.
That's so interesting, Ben. And I wonder if there was a use of like a time limited trial, if that would change, because I see a lot of turning points at day 14 before a trach. And then even for this gentleman, like you said, Dr. Vaughan, like maybe day 79, we would have had some information that we haven't seen the clinical improvements we had hoped to see.
Yes. And I would have honestly imagined that, again, if we kept in mind that they wanted what I would want, not meaning that they wanted the same things, their overall goal was that my dad get the best care. And so best care, I think, day 70, day 30, we could have helped shape earlier. And what I feel is that there was a tremendous amount of suffering on all parts. And I think in palliative care, we see that as a missed opportunity.
I'm getting overwhelmed by the little ones now. But yeah, there was one, now there's two. As people who are just learning language, hey, let me tie this in. I think it's so important to be intentional with the way we learn language, just as it's important for us to teach our trainees, right, who are learning the language of medicine, not to just use the word need, not to say, this is the way we have to go, but let's teach that next generation to be explicit about where we're going. Any other questions or thoughts for Dr. Vaughan? Well, I love this talk today, Leigh. Again, you've been awesome. A really stable mentoring presence in my professional life. So I'm grateful for that. Thank you for your time and enjoy your trip.
Thank you. And thanks for inviting me. I appreciate it. And good luck, Ben. We love your new surroundings. I think your new interdisciplinary team is pretty spectacular.
My interdisciplinary team. Can you guys say goodbye?
Goodbye.
Bye. Thank you.
Bye, guys.